Assalamu alaikum. Bismillahir Rahmanir Rahim. Alhamdulillah, with the completion of our course, now we are talking about the course recap. And the course was basically designed as a capacity building for all family physicians to achieve the standardization of diabetes care. The course started with global prevalence. 537 million, approximately 537 million adults at the age bracket of 20 to 79 years are living with diabetes. 643 million by 2030. The total number of people living with diabetes is projected to rise to 643 million by 2030 and 783 million by 2045. What a at present even. 3 in 4 adults with diabetes live in low and middle income countries. As far as Pakistan is concerned, the prevalence is overall 26.3%, 19.2% non-diabetic, and the 7.1% newly diagnosed. Total number of cases approximately 33 million. Risk factors: having a family history of diabetes, have a BMI equal or more than 23 kilogram per meter square, lead an inactive lifestyle, have high blood pressure, have abnormal blood cholesterol lipid levels, have a history of gestational diabetes. If they are more than 40 years of age, have impaired glucose tolerance or impaired fasting glucose, means they are known pre-diabetic. Classification of diabetes: type 1 diabetes, type 2 diabetes, gestational diabetes mellitus, that is GDM, and other specific types of diabetes. Pathophysiology: diabetes, genetic susceptibility, autoimmunity, environmental factors. Type 2 diabetes, defective insulin secretion by pancreatic beta cells and inability of insulin sensitive tissues to respond appropriately to insulin. As far as clinical picture is concerned, so the presentation of type 1 is excessive thirst, excessive hunger, unexplained weight loss, blurred vision, slow healing of cuts and sores, and fatigue, easy fatigue, vaginal yeast infection, and frequent urination, including frequent full diapers in infant and bedwetting in children. Symptoms of diabetes are increased thirst, slow healing of the cuts and sores, easy fatigability, frequent urination, unexplained weight loss. So, to have the harmonization as far as the process of diagnosis is concerned, the cutoff values are A1C about 5, these are the normal one, and fasting plasma glucose 99 milligram per deciliter or below, and oral glucose tolerance test 139 or below are considered as normal. As far as pre-diabetes is concerned, 5.7 to 6.4% is the A1C. Fasting glucose, plasma glucose 100 to 125 milligram per deciliter, and oral glucose tolerance 141 to 190 gram per deciliter. When this figure crosses and becomes more, then the label of being diabetic starts with the AAC 6.5% or more. Plasma glucose, fasting plasma glucose 126 milligram per deciliter or more. An oral glucose tolerance test, that is 2 hours after the meal, above 200 or above 200 milligram per deciliter. Glycemic targets once the treatment starts: A1C should be less than 7, that is 53 millimole per mole. Prandial capillary plasma glucose 80 to 130 milligram per deciliter. Peak postprandial capillary less than 180 milligram per deciliter. Glycemic targets in pregnancies: glucose increment, preprandial and pre-meal. Patients with GDM should have the equal to or less than 95 milligram per deciliter, that is 5.3 millimole. And pre-meal, bedtime and overnight glucose should range between 60 to 99 milligram per deciliter, that is 3.4 to 5.5 millimole per liter. Postprandial, post-meal, that is 1 hour post meal, it should be less than 140 milligram per deciliter, that is 7.8 millimole per liter, or 2 hours post meal, it should be less than 1 per deciliter or 6.7 millimole per liter. As far as the patients with pre-existing type 1 diabetes or type 2 diabetes, postprandial, peak postprandial glucose should range between 100 to 129 milligram per deciliter, that is between 5.5 to 7.1 millimole per liter. A1C should be managed below 6%. Right. For any disease, prevention has its own significance. So just in 30 seconds, one can assess the risk score of for developing diabetes. This rapid score comprises of only 3 questions. Number 1 is age, waist circumference, and number 3 is family history. If for question 1, if the person is less than 40 years of age, he should mark a score as 0. Between 40 to 50 years, mark 1, and more than 50 years of age, then mark 3. Waist circumference cutoff for males is less than 90 centimeter or 35.5 inch. And if they are less than that, then they should mark 0, and if it is more than that, then they should mark 2. As far as females are concerned, again further lower down, the waist circumference should be less than 80 centimeter or 31.5 inch, or if that is the case, then they should mark 0, if then should mark 2. And for family history, either of parents, that is father and mother, brother and sisters, siblings, so any of them, if any one of them is diabetic, that means the family history is positive. In that case, it should be marked 1. If there is none among the parents or sibling, then they should mark 0. If they add all the numbers what they have got, that and it comes out to be 4 or more, then the risk of developing diabetes is high, and they should contact doctor for the further workup and for confirmation of the diagnosis. Those who have less than 4 score in the rapid score, they should focus on reducing the risk by living a healthy life. And some of the essential features are: reduce weight and blood pressure, eat fresh vegetables and fruits, manage stress, straight away stop smoking, and exercise more. That is 30 minutes walk in during the week, every day, at least for five days, and stay hydrated. 6 to 8 glasses of water per day, or in summer season even more. Support healthy living and sleep well. As far as complications of diabetes is concerned, starting with the microvascular, diabetic nephropathy, diabetic neuropathy, nerve damage, diabetic retinopathy, eye problems, and as far as macrovascular complications are concerned, cardiovascular disease, stroke, and diabetic foot. The other complications could be high blood pressure, skin and mouth infection, diabetic foot ulcers, sometimes leading to amputation of limbs, vision loss, or sudden blindness. Non-pharmacological management. It was very well narrated that balanced diet, no smoking, no alcohol, no drugs, include physical activities and regular and not less than 8 hours. Diabetic drugs. Diabetics medicines are biguanides, sulfonylurea, pioglitazone, DPP-4 inhibitors, and SGLT2 inhibitors. Among these groups, you see biguanides, metformin. How does they work? They decrease the gluconeogenesis and increase insulin sensitivity, encourages weight loss, and rarely cause hypoglycemia. Side effects are GI disturbances, peripheral neuropathy, decreased B12 absorption, lactic acidosis, increased risk with renal impairment, and other notes contraindicated in acute metabolic acidosis. Monitor renal function before treatment and last annually. Sulfonylurea include gliclazide, glibenclamide, and glipizide, and they act on beta cells to promote insulin secretion, ineffective in patients without functional beta cells. And side effects are GI disturbances again, frequent hypoglycemia, and weight gain. The class of pioglitazone, the mechanism is the reduced peripheral insulin resistance, bone fractures, weight gain, and bladder cancer. They are contraindicated in heart failure, bladder cancer. DPP-4 inhibitors, vinagliptin, and linagliptins are available in Pakistan. So they inhibits dipeptidase 4 to increase insulin secretion and lower glucagon secretion. The side effects include headache and acute pancreatitis, and the other cardioprotective effect. SGLT2 inhibitors, a very good addition among the anti-diabetic medicine. SGLT2 inhibitors contains dapagliflozin and have empagliflozin. These two molecules are very much in use in our country. Inhibits sodium glucose co-transporters 2 to reduce glucose reabsorption and increase urinary glucose excretion. The side effects are UTI, diabetic ketoacidosis, and back pain, and they are cardioprotective effects and contraindicated in type 1 diabetes due to high risk of diabetic ketoacidosis. Different types of insulin available for use and to offer rapid acting, short acting, intermediate acting and long acting. Rapid acting with the brand names of the Novolog, Humalog and Apidra. Their onset is 5 to 15 minutes. Their peak comes 30 to 120 minutes and the duration of action remains 3 to 5 hours. For short acting, usually regular, so U100 Humulin R, Novolin R, U500 Humulin R and U500. So U100 30 minutes onset and 2 to 4 hours peak, 5 to 8 hours their duration of action. U500 again the onset is within 30 minutes and peak is 4 to 8 hours and 14 to 15 hours is the duration of action. Intermediate acting Humulin N and Novolin N, their onset is between 2 to 4 hours, 4 to 10 hours are the peak and 10 to 18 hours is the duration of action. Long acting insulin include Levemir, which starts working 1 to 3 hours and peak is 6 to 8 hours and duration of action is 18 to 20 hours. Lantus, which is Glargine, 2 to 4 hours, no peak, 20 to 24 hours action. Toujeo onset is 2 to 4 hours, no peak and 24 hours is the duration of action. Screening of complications. Nephropathy, type 1 diabetes begin with puberty. So after 5 years duration of disease, one should expect and should be done annually thereafter. Nephropathy type 2 diabetes starts screening at the time of the diagnosis of diabetes and should be done annually thereafter. Neuropathy, annual neurological screening with neurological history and neurological exam including sensory motor, reflex and autonomic response, complete foot examination. Retinopathy, annual examination of the eye including fundoscopy is recommended for all as a follow-up. For retinopathy at the time of the first visit, it should have a fundoscopy should also be done. CVD risk reduction, lipid management, statin for primary prevention. Age bracket of 40 to 75, CV risk is nil, moderate intensity statin, LDL less than 100 milligram per deciliter, in that range should be managed. 40 to 75, one or more cardiovascular risk factors present, then high intensity statin, LDL should be managed below 70 and LDL 50% from baseline. Age bracket of 20 to 39 with positive CV risk factor, reasonable to initiate statin, and more than 75 even CV risk is not there, reasonable to initiate moderate intensity statin, and more than 75 years CV risk is positive, continue statin therapy. Start antihypertensive treatment when blood glucose is persistently elevated more than 130 by 80 millimeter of mercury. The on treatment target blood pressure goal is 130 less than 130 by 80 millimeter of mercury, and aspirin therapy 75 to 162 milligram per day prevention is recommended. Right. Screening for diabetic foot is very, very important. In case of category 0, risk profile is no sensory neuropathy. Checkup frequency should be once in a year. But if the category is 1, that means the sensory neuropathy has sets in. So once every 6 months is recommended for checkup. And category 2, sensory neuropathy and signs of peripheral vascular disease and or foot deformities are there, then once every 3 months is recommended. Previous ulcer is there, that means the category is now 3, and once every 1 to 3 months the checkup is mandatory. Right. We should have a patient-centered care and decision cycle for patient-centered glycemic management, that we have to assess key patients' characteristics, current lifestyle, comorbidities, that is ASCVD, CKD, HF, clinical characteristic, that is age, glycosylated hemoglobin, weight issues such as motivation and depression, cultural and socio-economic context. Goals of the care revolves with and involve all the management plan. Goal prevent complication and optimize quality of life. To achieve that, one can start with assess key patient characteristics, then consider specific factors which impact on choice of treatment and shared decision making to create a management plan. The more and more the people with diabetes are involved in decision making, they are most likely to own the decision, and the compliance is much better. Agree on management plan and implement management plan. Ongoing monitoring and support has no substitute. It should and must be done regularly. And review and agree on management plan for to continue it further. So the goal doesn't change, that is prevent complications and optimize quality of life. Role of SMBG, self-monitoring of blood glucose, introduction to control. Glucose monitoring and SMBG. SMBG provides data to understand the dynamic relationship between glucose impacting factors and behavior. So glucose meter measures capillary blood glucose and blood sampling via finger pricking, and average 5 to 7 finger pricks per day for insulin therapy. Understanding the dynamics relationship between insulin, carbohydrate, physical activity and resulting glucose levels. So limitation of SMBGs are that they require finger pricking, not always convenient nor discrete. Measurements of blood glucose levels at single point of time. So no information on rate of the change of the glucose levels, on fluctuations. The IPDM concept, integrated personal diabetes management, which elements, consideration and principles were included, starting again with assessment. Where does a patient stand? What glucose does a patient have? What would he or she like to achieve, and what would be the like to change or not like to change. Collaborative care, participative decision making, inclusion of the patient in the evaluation and adaptation or modification of the therapy as required. Very important is the feedback, regular feedback on the achievement of therapeutic goals, Compliance with self-monitoring of blood glucose is recommended. Training, uh, counseling, positive error management, joint structured analysis of the course of therapy. They also that also embark on compliance and a good compliance. Agreement, written agreement on therapeutic measures until the next appointment. Diabetes Registry of Pakistan. No one can plan anything good for controlling any disease until and unless they know the burden and how to get the burden. That's the only way that the data should be available in a registry. And thanks God we have this. Buckeye, the Institute of has initiated it much earlier. So Diabetes Registry of Pakistan is a brainchild of Buckeye Institute of Diabetology and Endocrinology in collaboration with Diabetic Association of Pakistan, Health Promotion Foundation, facilitated by Health Research Advisory Board, Health RAB, and support of the Ministry of Health. First diabetes registry in Pakistan since 2016. Thank you.